Hello, wonderful staff of the Northwest Kidney Center, and happy fall to everyone. Today we will discuss a really common and important problem in the dialysis world, hyperkalemia or an elevated serum potassium concentration. It's a problem that we deal with every single day in our units, whether you think about it or not. And clinically, it's extremely important for all of us to be familiar with this problem because hyperkalemia is a potentially life-threatening disorder that can cause arrhythmias and sudden cardiac arrest. So we need to take this problem very seriously. This talk has three objectives. We'll review clinical problems associated with hyperkalemia. Second, we'll discuss causes of hyperkalemia among dialysis patients. And then finally, we'll discuss management options. Let's begin by providing some background on potassium. Let's begin with some fun facts about potassium. Potassium is a metal with the atomic number 19. It is the seventh most abundant element in the Earth's crust, so about 2.4% of the Earth by weight is made of potassium. It's a metal, but it's soft enough to cut with a knife, and it is the most abundant cation, or positively charged molecule, inside cells in the body. Now, most of the potassium in the body is located within cells. So 98% of all the potassium is inside of cells, and that leaves only 2%, the amount that we measure in the bloodstream, that is circulating in the blood. Potassium shifts in and out of cells, and that process is regulated by a bunch of hormones, such as insulin and these stress hormones called catecholamines. And the total body potassium content is regulated primarily by kidneys. So about 90% of the ingested potassium is excreted in the urine, while about 10% is eliminated in the feces. Primarily for research purposes, hyperkalemia is defined as a serum potassium greater than 5 millimoles per liter, although clinically we won't really worry about high potassium until the level exceeds 6. And it is a very common occurrence among dialysis patients. We know this from a number of studies, including the PORTEND Study. Bit of a stretch here, but it's the Potassium and Cardiac Rhythm Trends in Maintenance Hemodialysis Trial. Observational study of 102 U.S. patients on maintenance hemodialysis, and the purpose was to look at the prevalence of pre-dialysis hyperkalemia after the long interdialytic interval. So that is, if you're a Monday, Wednesday, Friday patient, they would measure the potassium on Monday before dialysis, and if you're a Tuesday, Thursday, Saturday patient, they measure the potassium before Tuesday's session. What they found was if you dialyze in a 2K bath, the prevalence of hyperkalemia was 37%, and if you dialyze in a 3K bath, the prevalence was 21%. Now, interestingly, patients undergoing peritoneal dialysis have a much lower risk of developing hyperkalemia than those on hemodialysis, in part because of the continuous nature of peritoneal dialysis. I mean, you get it 7 days a week, but also because of the fact that we use a lot more diuretics to promote urine production in peritoneal dialysis patients, and PD patients tend to retain what we call their residual renal function. So they still tend to make more urine, have more renal function at baseline than the hemodialysis counterparts. So they actually have more of a problem of hypokalemia, prevalent in 10 to 36% of the population. But today we're focusing really on hyperkalemia in the hemodialysis population. Which brings us to part 2. Why do we worry about hyperkalemia among hemodialysis patients? We worry about hyperkalemia because it can cause abnormal electrical conduction in the heart, or arrhythmias. On the left is a diagram from an electrocardiogram, or an electrical heart tracing. The P wave represents contraction of the top part of the heart, called the atria. The QRS complex represents a contraction of the bottom chambers of the heart, or the ventricles, and the QT interval shows the duration of electrical recovery following contraction. In hyperkalemia, you see an enlargement of the T waves. We call that peaking of the T waves. There's also loss of the P waves, or the atrial contraction. And then finally, the QRS complex, which represents the electrical current passing through the ventricles, gets wider and slower. So electrical current travels more slowly through the ventricles. This can progress to severe prolongation of the electrical flow or current through the heart and a slowing of the heartbeat, and eventually can progress to a severe arrhythmia such as ventricular fibrillation and cardiac arrest. Unfortunately, the current thrice weekly hemodialysis schedule lends itself to intermittent hyperkalemia. And this has been demonstrated in several studies, including one in 1999 published by Blyer that used data from the United States renal data system. Basically, it was a retrospective cohort study looking at the frequency of cardiac events among hemodialysis patients by day of the week. And what they found was that there was a higher frequency of cardiac death at the end of the long interdialytic interval, say a Monday for a Monday, Wednesday, Friday patient, or a Tuesday for a Tuesday, Thursday, Saturday patient, than any other day of the week. In contrast, non-cardiac deaths were evenly distributed throughout the week. These same results are shown in this bar graph. Basically, the highest risk of sudden cardiac death is around the first hemodialysis session of the week. So again, Monday or Tuesday. So these are the percentage of deaths that are due to cardiac dysfunction highest at the beginning of the week. Interestingly, the study showed there was a threefold higher rate of death in the 12 hours before the end of the long weekend interval. So the 12 hours prior to the, say, Monday or Tuesday dialysis session. But there was also Interestingly, the study showed there was a threefold higher risk of sudden cardiac death in the 12 hours before the end of the long weekend interval, so say before a Monday or a Tuesday dialysis session, but that the risk didn't go down after dialysis. There was a 1.7-fold higher risk in the 12 hours starting with dialysis after the session was completed. So why would there be a risk of sudden cardiac death before and after the long weekend? So why the higher risk of sudden cardiac death both before and after dialysis? Well, most likely it's due to electrolyte abnormalities, particularly potassium. Before dialysis, lots of patients have hyperkalemia, which increases their risk of an arrhythmia. But after dialysis, we remove so much potassium that they can develop hypokalemia, or low potassium, which is also pro-arrhythmic. So what happens is if you have a gradient between the potassium concentration inside the cell versus in the plasma, if the gradient is big, that can irritate the cell membranes, particularly the cardiac membranes, and that can cause arrhythmias. And finally, the rate of potassium removal may contribute to this. If you remove a lot of potassium very, very quickly, that may also irritate myocardial membranes. Interesting, there was a study published using Australian and New Zealand data that showed that this pattern of increased cardiac mortality after the long interdialytic interval in patients on 3 times weekly dialysis was not seen in peritoneal dialysis patients, in-home hemodialysis patients, or patients receiving more than 3 sessions of in-center dialysis per week. So it really is a consequence of our thrice weekly schedule and the long interdialytic interval over the weekend. Let's now turn our attention to causes of hyperkalemia. As you know, there are many causes responsible for elevating serum potassium concentration in patients with end-stage renal disease, and these include dietary intake, medications, missing dialysis treatments, the dialysis prescription, and other conditions and comorbidities. According to the U.S. National Academy of Sciences, the recommended daily adequate intake of potassium for healthy adults, so someone who has normal kidneys, is 3,400 milligrams for a man and 2,600 milligrams for a woman. And most of it, of course, comes from fruits and vegetables. Now, in patients with end-stage renal disease on hemodialysis, it's important to restrict dietary potassium intake, and most governing bodies suggest limiting daily potassium intake to 2,000 milligrams per day. This is really opinion-based. It's based on little scientific evidence, but it makes sense that they should consume lower than the recommended amount for patients with normal kidney function. We know from studies that higher dietary intake of potassium increases the risk of mortality. This is one study published in 2010 in the American Journal of Kidney Disease that looked at 224 hemodialysis patients in Southern California at 8 DaVita dialysis clinics. It was a prospective observational study assessing potassium intake based on food frequency questionnaires. And what they found was that in patients undergoing maintenance hemodialysis, high dietary potassium intake was associated with increased 5-year mortality rates. So they actually divided people up into quartiles, and this dark line here represent the highest quartile, and that had the highest mortality rates. Medications can also increase the risk of hyperkalemia, and these include antihypertensives such as ACE inhibitors. You might have heard of like lisinopril or enalapril. Close cousin is the class called angiotensin receptor blockers. These are other antihypertensives such as losartan, which can raise potassium. It's a medication called spironolactone, which some dialysis patients take. A lot of patients with heart failure take it as well, but it can increase the potassium concentration. Beta blockers, common antihypertensives and medications for cardiac patients. It's medication called digoxin, which we don't use very much anymore, but all of these medications and others can increase blood potassium levels in dialysis patients. How we dialyze our patients, specifically the potassium concentration in the dialysate, can also affect clinical outcomes, specifically mortality. So this is data from big international observational trial called the DOPS trial, or the Dialysis Outcome Practice Pattern Study. This particular study was published in 2017. And what they showed was that the use of 2K and 3K BAS had no difference or impact on the risk of all-cause mortality or arrhythmias. But the use of 1K BAS resulted in a rapid reduction in serum potassium concentrations and increased the risk of arrhythmia. There are also several other observational studies which have shown an association between the use of 0 and 1K dialysate BAS and sudden cardiac death. The goal in all of this management is to maintain serum potassium concentration within a normal range. We want to remove the potassium that accumulates in the interdialytic interval or between dialysis sessions. We want to prevent serious pre-dialysis hyperkalemia as well as serious post-dialysis hypokalemia. And frankly, this is difficult to do with conventional 3 times weekly hemodialysis. Now let's turn our attention to the management of hyperkalemia in hemodialysis patients. Hyperkalemia management in hemodialysis patients involves 3 options. 1, low potassium diet. 2, potassium removal with the dialysis procedure. And finally, a more novel approach, oral potassium binders to limit the amount of potassium that accumulates in between dialysis treatments. The low potassium diet is very, very important, but it's hard for patients to adhere to it. Of course, we tell them to limit potassium-rich foods, including fruits and vegetables and nuts and grains. But, the restricted dietary intake has to be balanced against all the other nutritional recommendations that we're giving them. And there are a lot. So for example, we tell them to eat more protein, consume foods, that are less likely to give you an acid load, don't drink a lot of water, etc. It gets confusing for the patients. Patients should be aware that, certain salt substitutes contain potassium. Those should certainly be avoided. And then also keep in mind that on the one hand, we're telling them to avoid, potassium consumption. On the other hand, we're saying eat more protein, and the consumption of more protein leads to more potassium and phosphorus intake and increases the risk of metabolic acidosis, which can also increase the serum potassium concentration. So overall, the advice for patients can be confusing, and sometimes it gets so complicated that they stop trying. In addition to a low potassium diet, we also remove potassium with dialysis. Each dialysis session typically removes between 70 and 100 millimoles of potassium. So in a patient on a 3 times weekly schedule, the total weekly potassium removal is between 210 and 300 millimoles of potassium. Most of this is removed by diffusion, which we'll talk about momentarily. Some is removed by convection, but primarily diffusion is the main tool by which we remove potassium. And that relies on a concentration gradient between the potassium in the blood and the dialysate. So there's lots of potassium in the blood, and of course, dialysis uses a semi-permeable membrane, and particles travel from an area of high concentration across that membrane to an area of low concentration into the dialysate. Most of the potassium is removed during the first part of dialysis, particularly the first hour. The lower the dialysate concentration, so if there's less potassium in the dialysate, the concentration gradient is even bigger, and then you will remove more potassium. So again, potassium removal by diffusion depends on the gradient or the concentration difference between the blood and the dialysate. We call that the delta K. So you've got a certain potassium concentration in the blood, certain concentration in the dialysate. Let's say it's 5 millimoles per liter in the blood, and it's 2, so a 2K bath, 2 millimoles per liter in the dialysate. So that's a gradient of 3 millimoles per liter, and that's what drives potassium removal. Looked at in a different way, during dialysis, during the first hour, in general, we remove about 1 millimole per liter of potassium, and you can remove more potassium if there is a bigger gradient, like if you use a 1K or even a 0K bath. So the larger the gradient, the faster you move potassium during the first hour. In the next 2 hours, the potassium might decline by another 1 millimole per liter. After dialysis, you can see the diagram, potassium reaches a nadir at the end of the treatment, and then it rises, but it takes several hours, between 6 and 12 hours, before the potassium concentrations between the extracellular and intercellular compartments have fully equilibrated. The point I'm trying to make in discussing potassium kinetics is that levels fluctuate a lot in hemodialysis patients. They dialyze, only 3 times a week, and so you see high potassiums before, low potassiums after, and then the potassium levels rise again. A more rapid post-dialysis rebound of serum potassium concentrations can occur if there's a greater serum dialysate potassium gradient. And the fluctuations in serum potassium concentrations probably is a significant contributor to the irritability of the cells, the cell membranes of the heart muscles, and that contributes to cardiac arrhythmias. So ideally, in managing hyperkalemia in this population, we really want to reduce the amount of fluctuation, or the amount of potassium levels go up and down. How can we do this? We can use longer treatment times. We could do daily hemodialysis. We could do something called potassium profiling, which we'll talk about. And finally, we can give people GI or gastrointestinal potassium binders. These include medications such as K-oxalate or sodium polystyrene sulfonate. There are a couple new ones called Peritoneal and also sodium Zirconium Cyclosilicate. Potassium profiling is theoretically possible. It's not done currently because I think it had to be done manually and the machines aren't programmed to do it. But basically it involves changing the potassium concentration in the dialysate during the course of the treatment. So in traditional hemodialysis, the difference in concentration between the plasma potassium concentration and the dialysate potassium concentration is highest in the first hour. So you remove most of the potassium during the first hour, and then that gradient changes. It gets smaller during the course of the treatment. In potassium profile, what you try to do is you try to keep the gradient constant, let's say at like 1.5 millimoles per liter throughout dialysis, so that you don't have such a swing. So someone came in with a potassium concentration of 5.5, in theory you would start them off at a 4K dialysate bath, and then you would change to a 3K and then to a 2K during the course of the treatment. This was done in a randomized controlled trial published in 1996 and showed that there was a lot less myocardial irritation or arrhythmias like premature ventricular contractions during the course of the treatment when they use potassium profiling. So again, in theory, potassium profile is an attractive option. It's technically feasible, but you'd have to have dialysate potassium in a separate program stream. You have to have manual setup, and there are no automated systems currently built into modern hemodialysis machines to make this possible, but it could be done. So, a third option available to us currently to minimize fluctuations in potassium concentration in the blood is to employ the gastrointestinal tract in removing potassium. So recall that about 90% of potassium is removed by the kidneys and about 10% is excreted in the GI tract and your feces. But the amount is probably higher in dialysis patients, and the GI tract can be employed to increase the amount of potassium excretion. There are three options. One is called sodium polystyrene sulfonate, or KXlate, which most of you have probably seen. And then there are a couple of newer options. One is called Peritoneal, and the third option is sodium zirconium cyclosilicate, or SZZ. First, we'll talk about sodium polystyrene sulfonate, or SPS, or KXlate. This is an ion exchange rosin, which was first used in the early 1950s. So we've been using it for 70 years in medicine. FDA approved in 1958 based on a very small study. And it binds to positively charged molecules or cations, so calcium, magnesium, potassium, in exchange for sodium. Works primarily in the large intestine where most of the potassium is secreted. Previously sold as SPS plus sorbitol, although current manufacturers don't put sorbitol in for reasons which I'll explain momentarily. Sorbitol is a sugar alcohol made most often from corn syrup. It is a sugar substitute. It's a laxative. Basically, it draws water into the large intestine, thereby stimulating bowel movements. And it's added to SPS to help eliminate the SPS potassium complex. So in other words, they take the binder and then you want to eliminate from the intestines as soon as possible to get rid of the potassium. Sorbitol in its own right helps get rid of potassium through the GI tract because sorbitol causes diarrhea, and diarrhea is rich in potassium. In fact, I've always wondered if it's the sorbitol that's the active ingredient in the SPS sorbitol combination. This is a study that looked at the amount of potassium in the feces with just sorbitol alone versus sorbitol plus SPS, and it looks pretty darn similar to me. In fact, for the 120 grams, it had more potassium in the stool than the combination of sorbitol plus SPS. So why don't we just give sorbitol to our patients as a way of getting rid of potassium in the stool? Well, there have been some case reports of colonic necrosis, or basically, injury, ischemia to the tissue lining the intestines with the use of this combination, KXlate sodium polystyrene sulfonate with sorbitol. And people said, well, it couldn't possibly be the SPS, it must be the sorbitol, which I've never really understood. And so now they took away the sorbitol, and now you can just get SPS by itself. SPS by itself tends to cause constipation, and so people take it, and then they oftentimes don't have bowel movements, and so you're really not getting rid of the potassium. So all of this has rendered SPS by itself a poor dietary potassium binder. For this reason, KXlate, while often used in dialysis patients still, is often considered by nephrologists to be a generally useless dietary potassium binder. Fortunately, we have other options. One of them is called Peritoneal, or Valtessa, FDA approved in October 2015. It binds free potassium ions in the gastrointestinal tract and releases calcium ions in exchange. Lowering of potassium is detectable 7 hours after administration. It's not absorbed, it's not metabolized, and it is excreted unchanged in the feces, which is very good. Potassium has been shown in the non-dialysis population to be very effective at lowering serum potassium. In one multi-center trial of 237 non-dialysis patients with hyperkalemia, they were given potassium, and 76% reached normal serum potassium levels within 4 weeks. In the second part, they divided up the potassium treatment and placebo group, and they found that recurrence of hyperkalemia was a lot lower in the potassium group. There have also been studies looking at the use of potassium in maintenance hemodialysis patients, observational and retrospective cohort studies, and basically all of them have shown that potassium can be lowered and fecal excretion of potassium increased in hemodialysis patients with this medication. Unfortunately, there's some black box warning with potassium indicating that the drug can only be taken 6 hours apart from any other potassium dose or other drugs due to binding. And this really limits its use because our dialysis patients take so many medications. This warning is not present with the other oral potassium binder we're going to talk about momentarily, called sodium zirconium cyclosilicate. Okay, so sodium zirconium cyclosilicate is a first-in-class of inorganic crystalline zirconium silicate compounds. It exchanges potassium and hydrogen for sodium in the intestines. It is highly selective for potassium trapping, so 125 times more than SPS. It's insoluble, stable, does not expand in water, and it's not systemically absorbed, which is very good for our patients. Several studies have demonstrated efficacy in both the non-dialysis as well as the dialysis population. For example, the HARMONIZE Trial was published in 2014 as a double-blind, randomized, placebo-controlled, multi-center study in several countries. It looked at 258 non-dialysis patients with recurrent hyperkalemia, randomized to various doses of SCZ. Primary endpoint was potassium levels from day 8 to 30. And basically, they saw a dose-dependent reduction in serum potassium. So the more of this medication you gave, the lower the potassium. The Dialysis study in 2019 was a randomized double-blind placebo-controlled study of SCZ in hemodialysis patients. It looked at 196 dialysis patients randomized to either placebo or SCZ 5 to 15 grams on non-dialysis days. And basically, significantly more patients maintained a pre-dialysis serum potassium between 4 and 5 after the long interdialytic interval when they used the SCZ. So very promising medication. Okay, time to summarize what we've learned today. We worry about hyperkalemia because there's a potential to cause cardiac arrhythmias. Optimal management involves avoiding significant fluctuations in serum potassium concentration. You don't want to have really high values and then really low values. It's very bad for cell membranes, and that's what we think causes arrhythmias. Management options include a low potassium diet, dialysis, and of course oral potassium binders, which we discussed. In general, avoid 1K dialysis baths because of the increased risk of arrhythmias and cardiac mortality. Sodium polystyrene sulfonate, what we're most familiar with, is not very effective in lowering potassium, but the newer agents, Peritoneal and sodium zirconium cyclosilicate, are very effective oral potassium binders that may help prevent some of the significant fluctuations in serum potassium concentrations that we see. The only barrier to their current widespread use right now is cost. They're very, very expensive medications, but I am sure that we will all see more of them in the future. Okay, quiz time. Time to assess your comprehension. Question number 1, why do we worry about hyperkalemia, or what is the number one clinical concern associated with hyperkalemia? That's right, arrhythmias. Prolongation of the PR interval, the QRS interval, leading to arrhythmias such as ventricular tachycardia and ventricular fibrillation. Question number 2, at what time in the weekly dialysis schedule is there the highest risk of dying from an arrhythmia? That's right. Monday if it's Monday, Wednesday, Friday schedule, or Tuesday if it's Tuesday, Thursday, Saturday schedule. And remember that the risk of death or having arrhythmia is highest not only before the dialysis treatment, but for 12 hours after the dialysis treatment. Question number 3, name 3 ways to manage potassium in dialysis patients. You got it. Diet, dialysis, and oral potassium binders. Question number 4. Which dialysis modality, peritoneal dialysis or hemodialysis, is associated with a higher risk of hyperkalemia? That's right, hemodialysis. In fact, remember with peritoneal dialysis, because it's continuous and it does a better job of preserving residual renal function, and we use more diuretics in this population, more patients tend to have hypokalemia, and in fact, the majority of peritoneal dialysis patients actually take potassium supplements. Final question. What dialysate bath, 1K, 2K, or 3K, is associated with the higher risk of arrhythmia? You got it. It's a 1K bath. This concludes the September in-service for the Kent Northwest Kidney Center. Thank you all for being so awesome, for taking such great care of our patients, and making the Kent Northwest Kidney Center the finest dialysis center on God's green earth. This is Andy Borkenbrough signing out until next month.